Okay, so thank you for having me. Today I'm going to be talking about when to change the treatment plan for your patients. Specifically, we're going to be analyzing diminishing returns in VA patients who are undergoing prolonged exposure therapy and cognitive processing therapy for PTSD. And this paper is currently in press at Behavior Therapy. So as Dr. Rosen mentioned, I have a CDA looking at PTSD outcomes in residential programs, and these are my other acknowledgments and disclosures. And as we know, patients have different trajectories of change in PTSD treatment. And in order to get patients to improve as much as possible, we need to be able to predict their outcome at the outset. So here's an example of a paper from Clapp and colleagues in 2016 showing that patients have different trajectories of change in trauma-focused treatment. Some respond right away, some have a more delayed response, and some are somewhat non-responsive over the course of treatment. And if we knew at the outset who is likely to be in these different groups, we could tailor our treatment. And a recent paper by Dr. Reddy and Dr. Lamp and Rausch and colleagues looked at data from the Atlanta VA to try to predict after a certain amount of sessions, after 8 sessions, in particular, how can we predict who is likely to respond? 8 sessions is a common metric used in psychotherapy, particularly cognitive behavioral therapy. So that's why this number of sessions was chosen. And if you look at patients who achieve at least 10% symptom reduction in those first 8 sessions, we find that those patients are much more likely to achieve meaningful change by the end of treatment than patients who don't achieve at least 10% symptom reduction. So in this study, we wanted to determine, looking across the VA system, first of all, do patients to continue to improve after receiving 8 sessions of an evidence-based psychotherapy? And then secondly, who is likely to benefit from additional sessions? So we looked at all VA patients across the VA system who had a PTSD diagnosis and received at least 8 sessions of documented EBP. Either prolonged exposure or cognitive processing therapy. And note that we only included patients whose clinicians use the note templates in CPRS. So this limits our sample somewhat. And in order to be included in our sample, patients were required to have at least 2 symptom assessments using the PCL-5, one at the beginning of treatment and one by session 8. And our outcome variable here was meaningful change, and the way we defined that was at least 50% symptom reduction using the PTSD checklist. Note that this is a pretty stringent criterion, so it's more stringent than, for instance, a 10% decrease in symptoms, which we would consider probably clinically significant, and in most cases it's more stringent than the criterion of falling below the cut point of 33, which we consider to be indicative of clinically significant PTSD symptoms. Here we're just looking at whether or not people were able to reduce their symptoms by 50%. And we defined an early responder as someone who achieved meaningful change by session 8. A late responder is someone who continued in treatment and achieved meaningful change later, but within a 6-month time frame. And then a non-responder was someone who continued in treatment but did not achieve meaningful change. And here's our sample size. So you can see we started off with 640,000 patients with a PTSD diagnosis in fiscal years 16 and 17. Of those, 30,000 initiated an EBP using the note templates in CPRS. Of those, 12,815 had at least 8 EBP sessions, and only 2,285 had 8 EBP sessions and 2 PTSD checklist measures. And again, these are only PCLs that are entered in Mental Health Assistant. So if clinicians entered the PCL into the note text, that wasn't captured here. So when we look at our number of early responders, late responders, and non-responders, you can see that 19% of our sample was early responders, 14% were late responders, and 68% were non-responders. That is a large number, but as Dr. Rosen pointed out to me earlier, it's important to mention that we're only looking at people who have at least 8 sessions of treatment because we want to figure out what to do at that decision point. So there are a substantial number of people who improve before 8 sessions, but we didn't include them in our sample because we wanted to answer this particular clinical question. So when we look at the PCL changes in these groups, you can see that in the total sample, PCL changes from 52 to 44 by the end of session 8. The early responders decreased from 48.6 to 16.7 by the end of session 8. The late responders decreased from 50.2 to 38.8 by the end of session 8, and then down to 18.7 by the end of treatment. And the non-responders only decreased from 54 to 47. And here are our descriptives. Just a few things that I wanted to point out is that 66% of the sample was service-connected for PTSD, and 33%, so a third, had a substance use disorder. And the way we defined that in our sample was someone who had a chart diagnosis of a substance use disorder at some point in the past year. Then when we took a look at the predictors of becoming an early responder, we found that individuals, non-white individuals, were less likely to be early responders. Those who were service-connected for PTSD were less likely to be early responders. And the average service-connected disability for early responders was lower than it was for those who are not early responders. Turning now to predictors of becoming a late responder, again, service connection is predictive of, if you are service-connected for PTSD, you are less likely to be a late responder. Female veterans were more likely to be late responders. And interestingly, those with a substance use disorder at some point in the past year were more likely to be late responders. And this is actually consistent with some other findings that we've had, that those with a chart diagnosis of a substance use disorder are no less likely to get an EBP for PTSD in the data across the system. And also we have some data to show that they're no less likely to drop out of EBPs and may even, in unadjusted analyses, be more likely to stay with it in treatment. So this is an interesting finding. But the strongest effect that we found was the amount of change in the first 8 sessions. So individuals who did not improve in the first 8 sessions or who worsened in the first 8 sessions were much less likely to become a late responder. So here you can see the distribution of PCL change during the first 8 sessions among patients who subsequently became late responders. And you can see that those who go on to become late responders have some degree of change in the first 8 sessions. In contrast, among patients who become non-responders, you can see that there's not much change in the first 8 sessions. When we plotted these data, looking at percent symptom reduction in the early phase against the likelihood of becoming a late responder, you can see that there appears to be a linear relationship between the amount of symptom change you experience in the first 8 sessions and how likely you are of becoming a late responder. And this horizontal bar here is the overall likelihood of becoming a late responder, which is 17%. So you can see that even if you have just a 5% reduction in the first 8 sessions, you boost your odds of becoming a late responder. And if you have a 20% reduction, you double your chances of becoming a late responder as compared to the overall average. So in conclusion, what we found is that for those who persist in treatment, and not everyone does, but for those who continue beyond 8 sessions, the strongest predictor of outcome is how much change you experience in the first 8 sessions. And for those who experience at least 20% symptom reduction, you have double the odds of meaningful change if you continue on in treatment. Implications of the study are that we need to know the next steps for those people who are probable non-responders. And so I've put up a variety of options here that I think are worth investigating. One is to increase supervision or consultation, because we know that this improves treatment adherence and improves patient outcomes. So this could be some low-hanging fruit for patients that we worry are at risk of non-response. Another option is to change the intensity of treatment. This could be increasing the frequency of sessions or finding some way to increase homework intensity, or sort of double down in another way. Another option is to augment treatment. There are a variety of options that are starting to be investigated for how to increase the potency of treatment. And the final option is potentially to switch to another treatment modality. After 8 sessions, that could be a good decision point to decide to try something else. And so these are some future directions that merit further study. Thank you.